All right. So this is neuropathology for December. First case, 60-year-old lady, 68-year-old lady with a flare up of shingles, progressive hand numbness. She's right hand dominant. That's her primary complaint. She doesn't have any radiculopathy, weakness, difficulty with fine motor movement, difficulty with balance or ambulation. She had a cervical spine tumor that was diagnosed and treated back in 1999. Since that time, she hasn't had any symptoms. On her exam, she's completely neurologically intact. See if anyone's online here. I guess Turkey. I think you're the only one online. Can you just tell me what you would do for this patient? Turkey.
Hey Vignesh, sorry, just signed in.
Oh, that's okay. Hold on. Let me go back real quick. So, 68-year-old lady, progressive hand numbness. That's pretty much her only symptom. She's fully neurologically intact on exam, with the exception of the hand numbness. Like
Okay.
what would you start with for the workup?
Yeah, so if she has only hand numbness, then yeah, I would, it could be either it's broad. It could be either cervical spine, it could be peripheral nerve, it could be also from the brain. Since she's, physical examination is normal, less likely cerebral. I might just focus on the peripheral nerve and spine. So I would do MRI of the C spine, possibly nerve conduction study.
Sure. We'll start with the MRI here. So this is the MRI that we got. We got the T2 first. Can you see anything here?
Yeah, so I can see that. So there's a C7 to T2. It seems that she had laminectomy before. And there's some fluid collection at that site. She also has severe degenerative disease, kyphotic neck. I would surmise that this fluid collection might cause some nerve compression.
Yeah. Well, is there anything you can see within the buccal sac? It's a little tough to see, but there's this sort of mass.
A lot of it's like waterway. So I've already leaned out of it and stuff.
Yeah, it's not. It's very difficult to see though.
Yeah, I'll go to the
I'm not
contrast.
sure what that is.
Yeah, I'll go to the contrast scan.
Oh yeah. So in contrast, I see there's a left ventrolateral contrast enhancing lesion. It seems that it's extradural, and that it's compressing the thecal sac.
Gotcha.
And it seems like it's stuck to the dorsal vertebral body.
You said, where did you say it was?
And it's also attached to the dorsal body of the thecal sac at the T1, T2 level.
Right. So probably a intradural extramedullary mass, right? From the way it looks. And based on the contrast enhancement. So just given that, what are you kind of thinking about for tumors in this location?
Yeah, so commonly, meningioma, schwannoma, neurofibroma. It doesn't have a dumbbell shape. It's mainly within the canal. It doesn't go through the frame, and so it's diffusely contrast enhancing. So this could be a meningioma.
Okay. Good. Yeah. So I think you got the major diagnoses. I guess we could do the slides.
Iniyet?
Yeah, Dr. Butaki.
So are you going to project the PDF that I sent you?
Oh yeah, sure. Hold on. Yeah, I can do that. Yeah, it'll pull it up for me. So this is it, right?
So this shows on low power on the upper left picture, a low power, a cellular infiltrated tumor in soft tissue. And on the right-hand side, looks like, on high power, you can see actually glandular structures and atypical nuclei. So, and this looks more like an adenocarcinoma on morphology. And on immunohistochemical staining at the bottom, you can see that it's very strongly cytokeratin 7 positive. This is a type of cytokeratin which typically is positive in tumors above the diaphragm. And it's also GATA3 positive. So the pathologist, the chest pathologist who looked at this thought that this was most compatible with a lung primary. So metastatic adenocarcinoma most consistent with lung. Did she have, or did he have any workup?
I think this was a meningioma, actually.
Well, you're not showing me a meningioma, though.
Is it this?
Okay, yeah, that one.
Okay.
Well, okay. I thought that you put the cases in order. So forget all this. This obviously is a meningioma. On the left side, you have, those dark purple spots, which are psammoma bodies. On the right side, you have a moderately cellular lesion on high power, bland, and morphologically homogeneous lesion. Next picture.
I think it's just that one.
That's it? Okay. Yeah, we did Ki-67. It was 1%. There are no atypical features. And this is a classic meningioma, close to being, psammomatous meningioma on the left picture. Nothing special about it, just a bland old grade 1 meningioma.
Thank you. Okay, Turkey, if you're still on, can you kind of go over, so this is gonna be a revision, right? Because she initially had this treated partially at another institution. So how would you go about, treating her? Or maybe Victor, if you're on.
Yep. Vic, could you just show me the image one more time?
Yeah.
So this lesion is eccentric to the left, but it's not completely ventral. So you could come at this from the posterior approach.
Mm-hmm.
See, when you come from posteriorly, you could even try to get away with maybe a left-sided hemilaminectomy and just see what you can resect that way.
Yeah, I mean, I think just because the supervision is probably easier to, go just open the whole old incision, go down to the dura, open the other durotomy that they made, try to take off as much tumor, debulk it, peel it off the dura, off the, medially from the thecal sac, and medially from the cord and follow it out and just come nice.
Sure. I'll be in a sec.
So just a little bit about, kind of this case. So meningiomas are about 25% of all intradural extramedullary tumors. Spinal meningiomas are about, between 1 to 10% about of all meningiomas. They're most commonly found in the thoracic spine. They're found within the spine. About 15% are higher in the cervical spine, and minority are in the lumbar spine. The most common risk factor that's been shown was high dose ionizing radiation in childhood. It's more common in elderly patients, usually PK, just kind of what we see in Miami, 60 to 70. There's a higher female ratio of about 4 to 1. But in the lumbar spine, they're about 1 to 1. The most common symptom is actually local pain, because sometimes when they're slow growing like this, you have time to accommodate. A lot of times you don't have neurological deficit initially when you see, but local pain is common. You can see it in younger people than 60 years old in the context of NF2. And the patients that have NF2 are more likely to have aggressive subtypes. The vast majority of these are benign. 70 to 90% are WHO grade 1. You can see some of the subtypes here. Of the WHO grade 1 meningiomas, 80% of those are the meningothelial subtype. The other ones that you can see are simomatous, fibroblastic, secretory. About 5 to 20% are WHO grade 2. The most common, which is clear cell meningiomas, arise with the dentate ligament. And then smaller minority are WHO grade 3. Most of them are in this location. They're intradural extramedullary. About 5% are purely extradural, and if you have those types, they're typically more aggressive. But another 5% have both intradural and extradural components. Obviously, with these meningiomas, you can't really resect the dura, kind of given where they are in the spine. So after kind of complete excision of the meningioma leaving the dura, the recurrence rate is still about 7%. And recurrence typically occurs somewhere between 5 to 15 years, 4 to 17 years after the initial surgery. As Dr. Gultekin mentioned, some of the classic pathological characteristics: cells packed together in whorls, fascicle, and syncytia. You have small bodies that are positive for both EMA and SSTR2 on stains. Here's the next case. Let me see what's on. Long are you on?
Yeah.
So this is a 62-year-old lady with 4 years of progressively worsening back pain, leg pain. Back pain it's not specifically radicular, but sort of goes from the low back into the groin, the posterior thigh, into the lateral aspect of the foot. The pain's worse when she's sitting or walking for a long time. It's better when she's lying down. She has the subjective left leg weakness. She feels like her leg sometimes gives out. She had a couple of injections, SI joint, left hip, left knee. None of it really gave her any relief. She actually does have a history of B cell and T cell combining with a deficiency in her history of rheumatoid breast cancer. Here's her exam. She's fully intact. What would you do for in terms of your next steps?
Next up, I would like to get some. I would like to get some imaging, perhaps a MRI, L spine.
Mm-hmm. All right, good. Well, they started with a CT scan when she came in. Did you can you see anything here? It's a little hard to see, but
yeah. So I see an axial CT. Looks like there's a right-sided hyperdensity that looks, adjacent to the spinous process and right lamina.
Mm-hmm. Yeah, exactly. This hypodensity here, right? So following up with an MRI, this is the T2 sequence.
So T2 sagittal and axial MRI of the L spine. There appears to be a T2 iso-intense mass, right-sided mass. That looks to be adjacent to the right lamina and right spinous process.
Yeah. This is the T1. Pretty pretty hypo-intense on T1. This is the contrasted T1.
Para hacerlo bien, una herramienta.
Just basically shows contrast enhancement. So Long, if you had to, kind of come up with the differential.
I guess a differential diagnosis for a kind of a well-circumscribed contrast-enhancing tumor of the L spine, say like a possible lipoma. Other possibilities would include, I don't know if she has like a cancer history, but would include possible metastasis as well.
All right, good. So, one thing you want to worry about is, kind of in this area, the paraspinal area, you're worried about sarcoma, whether it's kind of synovial sarcoma, which can sometimes arise from facets. You also, it's relatively uncommon and, wouldn't really have this exact kind of imaging characteristic, but things like osteochondroma, giant cell tumor, neurofibroma, but those are a little more rare. But this location of this tumor is kind of right next to bone. It's right next to the facet, a little bit farther away from the nerve root, but those are kind of the things that we're thinking about here. Let me go to the slides.
Vignesh, you said the patient has a history of breast cancer?
Yeah, she does. Yeah.
Did she get a PET scan?
No, she did not. At least not that I could see in the system.
So what was the indication for operating?
Well, I mean, she had like pretty bad axial back pain. It was like
I am in neurosurgery grand rounds.
She had like like her leg was giving out. She had like subjective leg weakness, but pretty bad axial back pain.
Listen in,
Was
Dr.
a leg?
Dr. Morrison, can you mute your mic, please? Yeah, the indication was that she had pain.
Either, and then they're gonna give me an appointment on their staff. Yeah.
Are we able to mute Dr. Morrison's mic? Yeah, the indication was that he had a biopsy done, and then the biopsy revealed something that required further treatment. And the indication for the biopsy was the pain. So she had an outside biopsy.
Probably just trying to get. Thank you so much.
Actually, go take it.
Is this okay? So, what did you guys refer to? She had an outside biopsy. That was.
Yeah, she had an outside biopsy with this was the pathology from the resection.
Okay, this one you see here on the big picture at the bottom. There's a black line. It's the inked resection margin. Okay, and then you see a layer of muscle, skeletal muscle, and then on the left upper corner or quadrant, you see the actual tumor, which looks fatty, but there are also solid areas. Okay, on the right side also, there are solid areas intermixed with fat. On the small inset picture on the right lower corner, you see the solid component. Okay, so this is a lipoma, but a special type of lipoma called spindle cell lipoma, which may look less fatty than the usual lipoma on radiology, number one. It may look intraoperatively, the texture may look different from a regular lipoma, but still it's a benign variant of lipomatous tumors. Okay, so that's the pathology.
I think that the biopsy was something similar. I believe Dr. Rosenberg read it, but it was from an outside institution.
Yes.
And I think he thought it was the same, and he had recommended resection with margin because there was a low chance for malignant transformation, something like that, if I remember correctly.
Completely, yeah. He saw the outside biopsy, and then he, I think, issued a comment on the latest pathology specimen saying that he compared the two, and he thinks that, putting two together, he still thinks that this is a spindle cell lipoma, which rarely recurs after even incomplete resection, but that's right.
Mm-hmm. And so just kind of, for the surgical approach, as Dr. Levy mentioned, the pathologist wants to try to get everything out with margins. We were able to expose around the muscle, stay above the tumor, below the tumor lateral, and just take the tumor with the limb, the spinous process. But as Dr. Gultek mentioned, there's a spindle cell lipoma. It accounts for about 1.5% of all lipomatous tumors. They're pretty benign and slow growing. So it's a little strange because typically these are from the subcutaneous tissues. They're pretty rarely in the deeper tissues, the paraspinal musculature. About 80% of them arise in the upper back, the posterior neck, and the shoulders that we've all seen. This is much more common in males. Most common age is about 40 to 70. The diagnosis is based on cytology, and the most important thing is to make sure it's not malignant or high grade like sarcoma, and you have to distinguish it from other soft tissue sarcomas like a liposarcoma. As Dr. Gultek mentioned, typically they're characterized by mature adipocytes and small uniform spindle cells with collagen fibers. Pleomorphic lipomas can also contain multinucleated giant cells. Typically, these things are syndromic. They're characterized by partial or whole chromosome 13 or 16 deletions around the region of the RB1 gene, chromosome 13. Some other tumors in this family are myofibroblastoma and cellular angiofibroma. Some of these tumors can demonstrate CD34 positivity, and the prognosis overall uniformly good because local excision of the tumor is completely curative in these cases. Next case, Adam, are you on? David.
Hey, yeah. Okay.
Hey. So this is a 61-year-old lady with, 61-year-old guy with bilateral posterior leg radiculopathy, about 5 years, 1 week of worsening back pain. His leg pain is symmetric both sides. He's been having some new numbness now in the right leg. Pain kind of goes down the back of both legs into the top of both feet. Pain's worse when she's standing and walking. On exam, he has numbness over the right L5 distribution. Otherwise, he's intact. What would you do for your next steps?
Probably want to start off with a CT.
Oh, perfect. So that's the CT here.
Yeah, axial and sagittal, and you see that you have a at about T12L1, you have like a lytic lesion that's taking out the pedicle, lamina, transition process, and the vertebral bodies. It's expansile.
Yeah. This is the MRI without. This is the T2, and this is the T1.
Yeah, so
contrast.
Well circumscribed, maybe weakly contrast enhancing mass lesion. Like I said, taking out the pedicle at 2 levels with cord compression. It's much more on the right, and it's paraspinal as well.
Yeah, and in terms of your differential, what are you kind of thinking about?
Extradural extramedullary lesions. So I'd suspect like a primary bone tumor versus likely a MET. Did you say this gentleman has a history of cancer?
I'm not sure if this one did, but yeah. But no, it's a good thought. Yeah. So enteric disease, multiple myeloma, primary bone tumors like osteoblastoma, osteoid-osteoma, aneurysmal bone cyst. And then within metastatic disease, you have these like osteoblastic lesions, you have osteolytic lesions, and then you can have, these lytic lesions that can become mixed osteoblastic. So do you know any like osteoblastic tumors off the top of your head?
So osteoblastic would be something akin to like lung cancer.
Well, yeah, I mean, most common prostate. osteosarcoma, medullary thyroid, and lytic lesions. Lung cancer, kind of GI cancers, most other ones, renal cell carcinoma, multiple myeloma, and then breast cancer, lymphoma, urothelial, they can later become kind of mixed osteoblastic. Reload the slides.
So this is that case that was mistakenly put before. Again, it shows an epithelial tumor, nothing, in terms of bone tumor, etc. This is a metastasis because it shows an epithelial tumor which forms glands on the right upper side and atypical cells, which you can see nicely delineated with the cytokeratin stain. Glandular formations infiltrating through soft tissue, and it is absolutely compatible with the radiology. I think this case was looked at by the chest pathologist. I sent it to him, and Dr. Brisky says this is most compatible with lung cancer, lung carcinoma. However, other possibilities couldn't be ruled out. Was this patient eventually worked up?
Yeah, they were subsequently worked up afterwards. But I don't have the specific results of that here, but they were worked up eventually. So. All right, so this was a metastatic adenocarcinoma. So David, in terms of when you consider surgery for this, there are kind of two considerations. One is, when you decompress, when you fuse. Then how does it affect, radiation treatment and so on. So how do you kind of make those decisions when you get a case like this?
Yeah, so one consideration is, if this patient has a neurological deficit, then there's an indication for decompression in this case, as well as needing eventual radiation. You want to do a separation surgery. The other thing is, given if there's structural injury and this patient's unstable, you would want to fuse them as well.
Right. Yeah, exactly. So this stuff like neurological deficit, cord compression, and need for separation surgery may need actual decompression. Based on the radiosensitivity of the tumor, you may have to be more or less aggressive if they come in, with multiple myeloma and they have a neurological deficit. Unfortunately, you do have to sometimes decompress in some of those cases to at least alleviate some of the neurodeficits, so then they can go to radiation later and receive radiation. They have instability with involvement of the pedicles or a large portion of the vertebral body. Or these large tumors, you have to fuse them to stabilize them, because sometimes these things can degenerate after radiation. You also have to watch for the involvement of the vasculature and other nearby structures, because these can sometimes involve the aorta and IVC anteriorly. So in terms of the surgical approach, what would you, what kind of steps of the surgery be here?
Yeah, so in this case, the midline approach would do laminectomies that would look like T12L lungs, or collision being. And then you can do like a transpecular decompression followed by instrumented fusion, maybe 2 levels above, 2 levels below.
Mm-hmm. Yeah, exactly. So, what you want to do is just try to decompress as much as possible, follow down those involved pedicles. The vertebral body is going to be involved as well. Try to decompress the thecal sac ventrally through, the space you have from falling down the pedicles. Just try to remove as much tumor as possible from the paraspinal musculature, and then because you can't put in T12L1 screws, just a T10 to L3 fusion that was done. So about overall, just a little bit about the epidemiology of this. About 10% of newly diagnosed cancers have vertebral body metastases. More common, older age, of course. Most commonly metastasis to the thoracic spine. In terms of kind of differentiating this from infection, because sometimes some of these can be, especially when they're smaller, a little difficult to differentiate from infection, but some, infection can involve the disc space, whereas these typically spread the disc space. Most commonly spread through through the bloodstream. Blood supply to the actual metastatic nidus typically is parasitized from the particular arteries, and radiation typically involves 10 sessions with a cumulative radiation dose of 30 to 40 gray. I don't want to spend too much time on this, but there are two things that you'll kind of hear about sometimes: the SIN score and the NOMS framework. So the SIN score is just kind of a relatively simplistic way of trying to characterize whether these things are stable, potentially unstable, or unstable. But this is kind of more, I think, for the use of, at least from what I saw, the use of primary care doctors, radiation doctors, to see if they needed consult neurosurgery. But the obvious things being obvious here, things that are tumors that are in the junctional levels, the ones that are lytic, the ones that have some sort of subluxation or deformity are the ones that are more likely to be unstable. And the NOMS framework, it's kind of a 4-point system, kind of looking at different systems within this to sort of see, to sort of at least guide decision-making process here. And then the last case, Adam, are you on? All right. Let's see. David, I'm just going to go back to you here. 48-year-old guy, 2 years after a car accident, now with persistent neck and left shoulder pain, occasional headaches. Had a left rotator cuff surgery, didn't get any improvement of the pain afterwards. Had this cerebellar hemangioblastoma, has a history of cerebellar hemangioblastoma that was resected in 2014 in New York. Now really primary complaint is this persistent neck pain. In the exam, he's hyperreflexic in the left arm, in the bilateral patella. Kind of what would the next steps be for this?
I mean, in this case, I would also get a CT followed by an MRI.
Mm-hmm. So, well, they got the MRI scan. What do you see here?
Yeah, so we see a T2 hyperintense intradural intramedullary lesion. It's pretty expansile.
Mm-hmm. And on the contrast, you see this. Oh, sorry, this is the non-contrast. And the contrast, you see this here.
Yeah, so it's contrast enhancing as well.
Mm-hmm. Yep, and your differential.
Yeah, so I mean, in this case, I would suspect something like an ependymoma versus an astrocytoma. Could also consider a hemangioblastoma given his prior history.
Yep. Yeah, exactly. This is intradural intramedullary, so things in this family: ependymoma, astrocytoma, hemangioblastoma, ganglioglioma, paraganglioglioma, rarely intradural metastases.
So this is a small amount of tissue. We typically receive small amounts of tissue for understandable reasons in intramedullary tumors, and the diagnosis may be a challenge, especially on frozen. So, but we make an effort to distinguish ependymoma from others. And here this shows a tumor. This is not normal spinal cord tissue. That's the first thing to do, to distinguish between the normal and the abnormal. And it's abnormal. Is it neoplastic or infectious? This looks neoplastic. It's like a homogeneous proliferation of cells. It looks like low grade. And on the left upper corner, there are some areas which remind me that they are like nuclear-free zones, perhaps around the blood vessel, looking like a perivascular pseudorosette. So I would be inclined to think that this would be an ependymoma just by looking at this next slide. And GFAP on the left upper picture shows an intensification of the GFAP labeling around the blood vessels, as you can see in the lower part of that picture. In ependymomas, that's what happens. Not every cell stains with GFAP, but the perivascular cells stain more. And the OLIC2 is typically negative in ependymomas, which is the case here. OLIC2 is another glial marker, nuclear marker, but ependymomas contain very little or none of that. So that's a good marker for us when it's negative. EMA shows punctate labeling, like dot-like labeling in certain cells, which also is very consistent with ependymoma. The Ki67 was low, around perhaps 1%. So in this case, despite the availability of scant tissue, we were confident about our diagnosis of grade 2 ependymoma.
Thanks, Dr. Buteyken. So the pathology here, grade 2 ependymoma. David, last question. What would the surgical approach be for this?
Yeah, so in this case, we'd do a midline approach, laminectomy, and then for the surgery after dural incision, you can approach the dorsal root entry zone or through the midline raphe and separate the PIA. In this case, in the eccentric, you could probably approach it through the dorsal root entry zone.
Right, exactly. Because this, just based on the kind of location here, you can see it's more eccentric to the left. So that was the approach that was taken for this. After your laminectomy, just confirm with ultrasound to make sure you're above and below the tumor. And then since you're entering through that left dorsal root entry zone, left paramedian dural chosen for this. Dissect toward the center of the cord, and then you can kind of debulk internally with the sonopet. The cyst will typically decompress as soon as you're there. So just overall for ependymoma, occurs obviously in both the brain and the spine. The spinal ependymomas are the majority of these. They arise from the central canal. Cranial ependymomas come from ependymomal cells of the ventricles. Frequently, you have these cysts associated with them. They're typically benign. Ependymomas account for about 60% of all spinal cord gliomas. The other ones are astrocytomas and GBM. There's a slight predominance in males with these, typically seen around age 30 to 40. There's pretty slow growing. You get symptoms from either the tumor and the associated cysts when they grow larger. But 96% occur in children. About half are in the cervical and thoracic spine. The other half are at the conus with myxopapillary ependymomas. The grading is based on the degree of malignancy that you see. So grade 1, two of the subtypes that are most common are myxopapillary ependymoma and subependymoma. So grade 2, you have classic cellular papillary clear cell antennacytic. Grade 3 is anaplastic. Genetics, they're frequently associated with the loss of chromosome 22q, but myxopapillary ependymomas are associated with the mutations in chromosome 7. You have overexpression of the MDM2 gene, which is involved in p53-mediated cell growth. Ki67 shows increased expression in some of the higher meningioma grades. Treatment, so you obviously want to try to take as much of these that you can without leading to any neurological deficit. And with regards to the cyst, if you can treat the tumor, typically the cyst resolves by itself. And if you're not able to get growth total resections based on the location of these, the radiotherapy consists of fractionated external beam radiation with a cumulative dose of 54 gray. And for patients that present with disseminated or metastatic disease, you do full craniospinal radiation.
Can you go back to the previous slide in the grading area?
Yeah.
Yeah. So in the 2021 WHO update of classification of CNS tumors, they actually upgraded the myxopapillary ependymoma to a grade 2 because of the fact that the recognition of the fact that local recurrence is similar to that of other spinal cord ependymomas. So I'd like to mention that. So the only grade 1 ependymoma is subependymoma.
Thank you for that. And that's all for neuropathology for this one.
Mm-hmm.
Vignesh, do you know any of the data with myxopapillary ependymomas and the radiation? Is there any studies?
Oh, sorry, I was muted. So I think typically, I know you treat these with surgical resection, and you try to do adjuvant radiotherapy, but I'm not sure about the overall long-term outcomes.
Like you mentioned, after gross total resection, what's the management? And then, you know, some centers do some things, some centers do other things. Like, you know,
not quite sure off the top of my head.
There was an amazing review done by one of the neurosurgeons here on an article that was published in Neurosurgery, 10 years ago, Dr. Shaw? Do you know who did that?
I think Rick was involved, maybe. I was involved as a medical student too, so. But
what are the results of that paper?
So it was a big study out of MD Anderson that looked at their retrospective case series in gross total resection for grade 1, I think mixed papillary ependymomas, and adjuvant radiation up front. And they had good local control rates after using that protocol. Obviously, the downsides were that if you gave radiation to these patients postoperatively, you'd have worsening pain, and you know, obviously long-term side effects of the radiation, because these patients tend to do pretty well and have a long life. So you have to counterbalance the effects of postoperative radiation after gross total resection.
Yeah, and again, we're specifically talking about myxopapillary ependymomas, not these ependymomas that were spoken about in the last case. So for typical intramedullary ependymomas, we try to get gross total resection and then no radiation, just follow. And similarly here for myxopapillary ependymomas, if it's gross total resection, we just follow them. And the only ones who get radiation are people who recur, which are the vast minority, or if something on pathology is concerning, it's like not a WHO grade 2, but it turns out to be, high mitotic index or something like that, then we would radiate up front. But I always thought that paper was a little aggressive. I mean, they radiated everybody and looked at the results, and I don't know if that's the right thing.
Agree. It's also interesting that if a posterior fossa ependymomas, are managed, very differently than spinal ependymomas. I guess maybe the risk of radiation and the molecular characteristics, but I always found that fascinating.
So good morning, everybody. Damian Brusco, one of the PGY3s. Basically want to, talk a little bit about a surgical topic, rather kind of series of approaches that now having some firsthand experience, particularly this year at the VA and now, has really become more of an interest of mine within spine surgery. And I think one that, comfort with in gaining lateral access throughout the spine will, prove very useful down the road, able to tackle many different pathologies that I'm going to touch on kind of throughout the talk. And, of course, lateral access is not a new approach, over the last, few years or so. It's been out for several decades. And however, what I think is interesting is that there's been a lot of refinements that have taken place more recently, in addition to the ones that took place when they was initially developed, that are continuing to improve upon many of the existing corridors or technologies, with the ultimate goal of obviously improving patient care, enhancing efficiency within the operating room. So I think it's a kind of a interesting topic to discuss, especially for me, kind of going into spine fellowship next year and starting to learn more about how to operate. So overall outline, obviously important to talk about the historical perspective. So we'll touch on that, kind of where spine surgery sort of began with different approaches and how it has translated to today in early lateral spine surgery, some of the initial papers from the early 2000s and those that were heavily involved and proponents of it. As well as some of the more current techniques and things that I've had the opportunity to be involved in as part of research, as well as clinically here in the ORs, and some of the things I've kind of picked up along the way and thought were very interesting to learn about. And then, of course, future directions and kind of some of the newer, more maybe controversial techniques, things that people are doing out there that haven't quite gained as much traction as the kind of standard lateral approaches, but that have the potential to potentially become increasingly popular. So often stressed is the importance of the historical context in which new surgical techniques are discovered or pioneered. Typically, this is a result of either the challenges observed with these particular techniques or the pathologies at the time that require surgical intervention, or as a result of new technologies that make possible what previously was not. And spine surgery is no different. Both of these driving factors have led to a number of important advancements during the last several decades I'd like to kind of touch on. Of course, we all know Cambin's triangle, although more recently it's been called a prism to better characterize that three-dimensional anatomy, that we see in the OR. It was initially described in 1973 and provided this posterolateral corridor to the lumbar disc space. Kind of following that, in 1975, Hijikata described an early form of percutaneous discectomy. It involved partial resection of the disc material, again, via this posterolateral approach. And it was all done under local anesthesia. And then in the 80s, Cambin further refines this technique, introduces fluoroscopy for these percutaneous discectomies, and even used arthroscopy and different techniques there to enhance this approach. And interestingly, he repurposed some instruments that were similar to those used for ophthalmologists to remove vitreous humor within the eye. And he redesigned these for use in his discectomies. And then what I thought was also interesting was that even laparoscopy was borrowed from the general surgeons for anterior access to the lumbar disc space, which does make sense. Obenkind in 1991 described this anterior laparoscopic assisted discectomy approach. But it was just 4 years after the initial laparoscopic cholecystectomy was performed on a human in France in 1987. So very early on, spine surgeons have shown that they're adopters of many of these new technologies and to gain access into these different corridors within the spine. And so while Cambin and others, pioneered these new anatomical approaches, using variants of existing surgical tools like arthroscopes, further developments came in the 1990s when new technologies such as tubular systems for the microdiscectomy, like the metric system, are still commonly used today. And so the initial prototype before the metric system was the MED, microendoscopic discectomy approach, but the lack of depth perception and stereoscopic visualization with the endoscope sort of compounded the steep learning curve associated with these procedures. And so it wasn't really until the second generation metric system really enabled the use of the operating microscope and kind of freed surgeons up a bit more in the OR. And now, as we all know, it's become the standard technique for discectomy, including variations like IPSI contra decompressions and MIST lifts, and it's really become a very useful tool. And so, of course, these minimally invasive posterior transforaminal approaches have become increasingly popular, and utilizing these new, once new surgical corridors like Cambin's triangle to, remove disc and place interbody grafts. And so it's whether these mini open, tubular, or endoscopic approaches have become now a mainstay for lumbar fusions from a more posterior approach. It's yet again another example of how this access combined with new technology has fostered this new standard of care. And so that's sort of concurrently, triggered, surgeons to look for different access, different avenues to reduce morbidity and challenge themselves to identify new ways to treat lumbar pathologies. So during all of this, concurrent advancements were made for spinal fusions from an anterior approach, which is not new, even dating back all the way to 1933. Burns was the first to report anterior lumbar fusion for spondylolisthesis. But many decades went by without significant advancement. It wasn't a very talked about topic. And again, laparoscopy was quickly adopted just a few years later by Obenkind, as I mentioned, which further aided in fusions. In 1995, Matthews and Zuckerman each separately described a laparoscopic ALIF approach, which is seen here in the images at the bottom, to visualize and then place an interbody graft, similar to what we do today in an open approach. And so as expected, they reported patients experiencing shorter hospital stays, less blood loss, and as the surgeon's learning curve with the laparoscope improved, the operative time shortened as well compared to the more open approaches. And so as surgeons explored, became more comfortable with the posterior and anterior approaches to the spine, attention was subsequently turned to lateral access. 1963, Iwahara described a retroperitoneal approach to the lumbar spine, but it wasn't really until the 1990s where urologists actually really began exploring the retroperitoneal cavity with an endoscope known as retroperitoneoscopies. And these were kind of pioneered by Gower and McDougall, were using balloon dissection of the retroperitoneal space to inject air in a balloon to dilate and open up that cavity, enabling visualization of the surrounding anatomy. And over time, these techniques eventually gave rise to applications for the treatment of lumbar disease. Luis Pimenta, initially describing the lateral lumbar interbody fusion in 2001. And of course, that then developed into the NuVasive extreme lateral lumbar interbody fusion. Medtronic has their direct lateral. And so these are all modifications kind of this initial approach, depending on the technologies that are used. But what are the advantages? Why did surgeons look for different access, different approaches to the spine? Well, compared to posterior approaches, there's reduced muscle disruption, splitting the muscle fibers along through the psoas and through the abdominal muscles more superficially, results in less pain, leads to faster recovery times. Compared to anterior approaches, there's avoidance of some major vascular structures, although with the OLIF approach, which I'll talk about towards the end of the talk, that is sometimes a concern as well, and must be taken into consideration. And at the same time, they were demonstrating high fusion rates, still the ability to treat spondylolisthesis, grade 1, 2, spondylolisthesis via an interbody approach, similar to what the TLIF and these posterior corrections were able to achieve. So it was proven to be safer, efficient, and still demonstrating the same efficacy in terms of fusion rates and treatment of the actual pathologies, and is why it picked up traction. And so then 2006, Osgore publishes this extreme lateral interbody fusion, describes this technique for his sort of retroperitoneal transpsoas approach, using mostly finger dissection to develop the plane. It was more of a blinded approach, using kind of 2 incisions and then tracking the dilator down, and using stimulation to make sure that the lumbar plexus was out of the way as they approached the disc space. And then in comparison to Osgore's initial technique, when I was a medical student here, I had the opportunity to help with a paper with Dr. Sellin, one of our former spine fellows, and Dr. Levy, to look back on his series of lateral interbody fusions and how we over time modify that initial technique to avoid some of these common complications associated with the approach, such as thigh sensory dysfunction, femoral nerve injury, psoas weakness, and pseudo hernia. And so, we described his mini open approach, allowing for more direct visualization of the actual anatomy, which is not possible with Osgore's 2-finger technique. It's more of a blinded approach. Dr. Levy used an exclusive muscle splitting technique through the psoas, as well as first look direct visualization, so that no muscle fibers were cut, either on the superficial abdominal muscles or deeper down within the psoas. And using these dual retractor shims and bone anchors to help stabilize once down at the disc space. And the results were pretty striking. There were no instances of femoral nerve injury in the with the modified approach, and the incidence of psoas pattern weakness and like groin and thigh sensory dysfunction on the ipsilateral side was significantly decreased compared to the historical cohort prior to these changes. In addition to some of these early lateral approaches to the lumbar spine, surgeons were also exploring lateral access higher up in the thoracic and thoracolumbar junction, particularly for thoracic disc herniations or tumors, which continue to pose big challenges for surgeons today. So one of the approaches, the lateral extracavitary technique, provides, while still done in the prone position, provides a more lateral approach to the ipsilateral side, requires taking down the rib. And there is, several case series reported on as early as 1984 in the literature. So again, this is sort of one of the earlier instances of these lateral access, as well as video-assisted thoracoscopy and transthoracic approaches to also tackle some of these disc herniations. And so I'll just kind of briefly touch on some of the anatomy and different anatomy of the thoracolumbar junction and some of the different approaches that can be used here. So the retroperitoneal is the sort of standard approach for lesions that are below the diaphragm, T12 sometimes to L2. And it's important to know and understand that the retroperitoneal space and the retropleural space are continuous compartments that are really just separated by the lateral attachments of the diaphragm to the 11th to 12th ribs and the L1 TP. And so depending on the level and regional anatomy of the patient, if you're trying to access, for example, the T12 L2 disc space, generally the main operative corridor is purely within the retroperitoneal space. However, if there's a high, a rib cage overhang or, makes somewhat aberrant anatomy, mobilization of the diaphragm can be kind of lifted off and mobilized superiorly by mobilizing its lateral attachments. But if access is needed sort of above that, T11, 12 disc space, then the general working corridor tends to be within the retropleural space, completely within the actual chest cavity. And of course, pathologies that require intervention on multiple different levels or if greater exposure across multiple levels is needed, then a combination of these techniques can be used. And so this is just another picture sort of the kind of intraoperative, more of an intraoperative view of what we see in this kind of position, anterior in the front, posterior at the bottom of the screen, with that separation of the retroperitoneal retropleural spaces, sort of on the left side of the screen, separated by that chest cavity with the lung and the visceral pleura, all kind of marking the border along that 10th rib there, and ribs 11 and 12 have been cut in that picture to visualize that T12 vertebral body there. So now that we've covered many of the common corridors used for lateral access that have sort of historically been developed, there's still continued innovation and technological advancements related to those approaches. I'd like to focus on two of those that are becoming apparently increasingly prevalent, something I've had the opportunity to either work on in terms of research or see in the operating room and or both, and may potentially become the new standard going forward for different spinal pathologies, of which I'll get into now. So the first one I want to focus on is the ACR. So one of the current trends in adult spinal deformity has been development of less invasive techniques to treat complex deformity. Traditionally, variations of posterior osteotomies ranging from Ponti osteotomies to pedicle subtraction to VCRs have been used to achieve correction and realignment of the spinal pelvic parameters. The Schwab classification there in the top of the screen, shows that, progressively more and more bone and part of the vertebral bodies are taken. As you can imagine, this is very good to correct and align, particularly with sagittal deformity, but the morbidity associated with these procedures is incredibly high: long operative times, high blood loss, extended recovery within the hospital, ICU stays, all contribute to potentially poor outcomes for patients. And furthermore, high rates of instrumentation failure over the long term can make revisions, more common occurrence than they probably should be, which further complicates outcomes. And oftentimes these patients go for multiple revisions, and these complex deformities can quickly become more and more difficult to treat. And so then, the question became, can minimally invasive deformity approaches provide the same power for correction as an open osteotomy? And I'm not going to get into the nuances of MIS deformity today. That's kind of a big topic, a separate talk for another day. But it is worth noting that the multi-level laterals are more commonly being used to treat the coronal imbalance and coronal deformities, trying to reposition the spines and realign them coronally. But today I'm really just going to focus on the correction of sagittal imbalance with ACR, or anterior column realignment or reconstruction. And it's one technique that's used as a less invasive approach to correcting sagittal imbalance. So similar lateral transpsoas access to the spine, similar to that for an interbody fusion, but it's combined with anterior longitudinal ligament sectioning and or release at the same time from that lateral approach. And so by releasing the anterior column support, or the ALL, it allows for greater lordosis than the standard L-lift graft. It's hyperlordotic cages, typically requires posterior instrumentation, and I'll show you an example here. This is a patient on the left that had prior lumbar fusion, no interbodies, with an L1-2 kyphotic deformity at the rostral, just above at the rostral level of the construct, that subsequently required an L1-2 ACR with extension of their percutaneous fusion. And so you can see the pretty hyperlordotic cage, that ALL, which has now been cut, as that anterior column is completely released. much more lordosis than previously seen, where it was a kyphotic deformity. Now it's nicely lordotic. And there's 2 anchoring screws. It can be done with 1 anchoring screw or 2 anchoring screws, either above or below on the either superior, inferior vertebral body, but it does require an anchoring in there to fix that graft in place so it doesn't slide out, because there's no ALL support back there. So the only real study to compare these outcomes between ACR patients and PSO patients is a paper from the ISSG in 2017 that compared the radiographic and complication rates of a propensity matched cohort of patients with similar pre-op parameters, including pelvic incidence, lumbar lordosis, thoracic kyphosis. Propensity matching is actually something I just recently learned about and kind of working on some of these studies. And essentially, if you have 10 ACR patients, they then look at and there's probably 100 PSO patients or something from a kind of historical database. It will find do a statistical analysis, and it will match baseline characteristics like age, gender, BMI, in addition to whatever parameters you want. In this case, spinal pelvic parameters that I mentioned, PILL, thoracic kyphosis. And we'll match those to a cohort of 10 ACR patients. So you have 10 ACR, 10 PSO patients that are matched based on all the characteristics you're hoping to rule out, meaning that basically you have patients A and B, 1 ACR, 1 PSO patient, that have very similar spines in terms of their overall baseline deformity. And that allows you to better assess, is your intervention with the ACR or the PSO actually contributing to the overall patient's outcome and their realignment. Of note, in this series, one of the earlier series, the ACR patients underwent ACR with subsequent open posterior instrumentation. That was usually in like a second stage procedure. And so overall, the study showed that ACR did achieve similar radiographic results as PSO in this propensity match cohort, but did that with significantly less blood loss and similar complication rates. So this is one of the tables from the paper that highlights the change, the delta, the change in from baseline at 3 months and then at 1 year for both the ACR and the PSO groups. And then they compared them, and the p-values there are showing a comparison between groups. All of the asterisks on in each of the columns for ACR and PSO 3 months and 1 year are within group significance, meaning that there was a significant change in, for example, lumbar lordosis in the ACR group at 3 months, which was maintained at 1 year. However, comparing PSO to ACR, there was no significant difference between those 2 groups. So overall, it does show that there was an improvement from baseline significantly within the ACR group and separately within the PSO group. But between each of the 2 groups, there wasn't much of a difference, meaning that ACR tended to achieve just as good of a correction, from a radiographic perspective as the PSO patients. And so then importantly, we demonstrated that the complication rate was also similar, albeit a little bit less, 35% in the ACR patient compared to 41% PSO, both still very high. And although the complication rates were high, the types of complications were different and based on surgical approach, as one might expect. So in the ACR group, there were 3 instances, 3 complications of a motor nerve deficit of severe quadriceps weakness after surgery. And 1 case of common iliac artery laceration that actually required some vascular surgery intervention to treat it. Additionally, there were also in the second stage posterior surgeries, multiple complications due to the posterior open pedicle screw instrumentation. And those were sort of similar to the PSO complications that we're seeing. So, of course, there's always a learning curve and with new procedures. In this case, the longer retraction time needed to do an ACR, greater changes in the segmental alignment with a hyperlordotic cage increase the risk of lumbar plexus injury, particularly at L4-5. Most of those, or all 3 actually, of the motor nerve injury patients had ACRs done at the L4-5 region. And so the authors posited that the more anteriorly positioned L4-5 plexus makes it an ACR more challenging and may be responsible for the increased rate of motor weakness in those patients. Furthermore, several of the complications in the ACR cohort occurred during the second posterior stage of the procedure. And so things like percutaneous pedicle screw placement may obviate or at least reduce some of this risk by reducing OR time and estimated blood loss. And adjuncts like fluoroscopy, navigation, robotics can be further used to increase efficiency based on surgeon comfort and what they're hoping to achieve. So that may also help in studies down the road. And that's something we've actually kind of looked at now. So working with Dr. Wang as part of the ISSG group to compare this multi-center cohort of ACR patients, of which we have 24 now, with minimum 1-year follow-up, comparing them to, again, propensity matched 24 PSO patients with the same spinal pelvic pre-op parameters that was used in the first paper I just mentioned. And so far, the results have continued to be encouraging. Despite the ACR patients being significantly older, they experienced less blood loss on average, as well as underwent fewer instrumented levels, meaning that they required fewer posterior instrumentation to back up the ACR compared to the PSO group. So, of course, this last point, will require some long-term follow-up to determine if the rates of non-union or PJK requiring revisions are higher in the ACR group with these shorter constructs. But we do have some recent data as well that we examined from this same series that demonstrates, in the absence of developing PJK over time, these long fusion constructs with pedicle screw or with percutaneous pedicle screws above the highest interbody level, as was shown on that X-ray earlier. It demonstrated only one case of screw loosening over those 2 years. So it does appear that these are effective constructs and that are holding up over time. At least over the 2-year mark. But as we know, sometimes these patients come back, 2, 4, 3, 5 years down the road. So will be something to kind of keep an eye on as these patients are followed long term. And so the real kind of crux of the paper was to look at, or of the study was to look at sagittal correction. And so we looked at sagittal vertical access improvements in both the ACR patients and PSO patients. PIL mismatch also improved, although these differences, again, were not significant, similar to the previous paper. We took it a step further as well and looked at patient-reported outcome measures. So ODI improved 21 points in the ACR group compared to just 16.5 in the PSO group, both of which are good improvements, but again, not significant between the two groups. And similar improvements were seen for ACR and PSO in the SRS 22. This time, PSO patients had slightly better improvements, but again, was not significant. And of course, complications were also analyzed, and the rate of intraoperative complications and postoperative, like medical complications associated with the morbidity of the procedure, were also actually significantly less in the ACR group compared to PSOs by a pretty large difference. So that's certainly encouraging. I think as the learning curve, as surgeons are getting better in this series of doing ACR, is becoming more comfortable, that complication rate should hopefully continue to improve. So what are the next steps as far as ACR? Where is it headed? Well, I think kind of continuing to demonstrate the efficacy and safety of the procedure is paramount, and comparing them to what's already being done, multi-level lateral fusions, PSOs, and trying to compare the degree of segmental lordosis that can be achieved with an ACR graft as compared to a lateral or an osteotomy. And looking at that difference, and if there's either more of an improvement or at least some equipoise there without all of the complications associated with the extensive PSO or other osteotomy surgeries, I think will help standardize this as a more popular approach. And additionally, long-term studies to assess fusion rates, maintenance of alignment over time, as I mentioned, are going to be important as well to show that this is effective and durable. And then, of course, complication avoidance, continuing to improve the efficiency and safety in the operating room and postoperatively.
Hey, Damien, quick question. I hate PSOs, and I think ACRs are great and a huge advance. But I think that what happens often is, we use it for PJKs at the, L1, L2 level, sometimes higher, but and we do get good correction at that specific level, but because it's always done higher, I wonder if anybody's looked at the global correction of ACR versus PSO, because when PSOs are done, they're typically done in the fusion mass, and they're done lower down, sort of L3, L4. And I wonder if 30-degree correction at a lower level is better than a 30-degree level. I'm wondering if anybody's looked at that.
Yeah, that's something that we're going to be looking at. It not only like segmental lordosis, but also global realignment. But actually, in the out of those 24 ACR patients, most of them were actually at lower levels, around like L2-3, L3-4. That image I showed was at L1-2, but that was sort of more the exception in terms of treating PJK. But a lot of the patients that we saw either had multi-level ACRs. There were a number that had like, one or two, or like two, or sometimes one patient had 3 ACRs all within kind of the lumbar spine as well to really improve lordosis. So, I think it can be done lower down. It can pose some problems at, L4-5, but as, surgeons become more comfortable with some of that anatomy, I think it has the potential to become just as effective in treating, more true lumbar segments.
But for a PJK, when someone's fused from 3 to 1 or 2 to 1 and they develop kyphosis, which is again one of the common scenarios, you can't do an ACR at those lower levels. You can't do an ACR through a fusion, while a PSO is usually done at the fused site, and you work through the fusion. So I just wonder, like, maybe because they were matched, it didn't take that into account. But something to think about is that, and that's certainly true for ankylosing spondylitis patients who are kyphotic, that it's important to get these corrections lower rather than higher.
Mm-hmm. Alan, it's Mike Wang. That's a great point, and this is something I've been trying to get Sumedh and some of the other guys involved in, which is this Rasooli, harmoniousness of correction, not just the degree of correction, but the harmoniousness of the positioning. And you're absolutely right about the ACR issue usually being higher up, and you saw the complications at L4-5. So I guess Damien's going to get to this with what Timur's doing with OLIF, but it's a really interesting and exciting area with finally some science behind it. So that was an excellent comment and question.
Hey, Dr. Wang, this is Shelby. How with the Rasooli classification, how do those PSOs in the upper lumbar spine, why do they fail, do you think? Because I think that's what they're kind of showing, right? Is that the upper lumbar PSOs have a higher failure rate?
Yeah, I don't
good.
Yeah, it's very interesting because obviously the spine has to function, to hold the body together.
Mark is on vacation.
Somebody's loud. That sounds like James there. Anyhow, it's very interesting because I think we're starting to finally understand. And now it's interesting. Not only we're talking about 36-inch standing films, but now with the EOS, they're imaging the ankles and the shoulders and all this. So it's very interesting. I think, Shelby, we don't really understand why. That's why we really want to study this deeper and model it mathematically. It's obvious to see that if the curvature of the lordosis happens at L2 instead of L4, that there's going to be some difference in how the spine looks globally, right? But to quantify and get some kind of root cause or a mechanistic research in there is really an area that we need to go to. So that's a great comment. I think it's very cool what's happening now.
Mm-hmm. Yeah, no, thank you both for those points. So yeah, certainly something we're going to continue to look at. We've got now this nice cohort with like innumerable variables to be able to mine and look at all these different relationships. It's definitely going to be exciting to see going forward what we can pull out. But switching gears here a little bit and kind of talking about single position surgery, a little bit more divisive of an issue depending on kind of who you talk to. It's kind of come about as a way to shorten operative times, potentially improve outcomes for patients. There have been, a number of reviews and some meta-analyses that have looked at different papers that have examined, single position and dual position surgeries. And what the papers have been demonstrating is that shorter operative time and hospital stays are decreased in this single position group compared to the dual position approaches. One analysis actually even looked at prone single position surgery, which was found to be longer in overall duration and have increased radiation exposure compared to just the lateral single position, more standard approach. But the advantage of the prone single position was that it did increase some postoperative segmental lordosis, and I'll touch a bit on that towards the end of the talk as well. But the main learning curve, the real learning curve for a single position surgery tends to be the placement of the pedicle screws within the lateral position. And so the aid of navigation robotics certainly speeds up this process, but still can be a bit challenging. And even newer techniques to mitigate placing pedicle screws in the lateral position is prone, like I mentioned, but accessing the inner body via that lateral incision kind of poses new challenges and sort of variant anatomy for the surgeon that may kind of have surgeons shy away from that approach. So really, at the end of the day, it comes down to kind of surgeon comfort and what you're comfortable with, whether you use navigation, robotics, what kind of positioning you'd like to use, as to whether that's going to be a good option, for you and for the patient. And so additionally, the OLIF or anterior to psoas approach has become more widely adopted as sort of an alternative to this true lateral interbody fusion. The positioning is very similar. And in 1997, Mayer was the first to describe this technique, but which eventually was actually named the OLIF, the oblique lumbar interbody fusion, by Silvestre in 2012. And it mobilizes the psoas muscle completely posteriorly, which including the lumbar plexus, so it minimizes need for the neuromonitoring within the psoas muscle because we're avoiding the majority of that lumbar plexus, and the peritoneum is mobilized sort of anterior and superiorly to provide access to the lumbosacral spine. Similar though to a pure anterior approach, the venous anatomy can make adequate exposure difficult and or sometimes impossible to safely treat, particularly at L5S1. Other complications that are more similar to lumbar to the lateral fusions are transient thigh numbness and hip flexor weakness from psoas retraction. And I'll touch on a couple of pictures towards the end about sort of the OLIFs and some of the intraoperative experience I've had with Dr. Yurkov doing these so far at the VA. So kind of continuing the trend towards future directions, ACR, single position laterals, OLIFs becoming increasingly popular techniques that have really continued to push lateral access forward. And using new technologies, robotics, navigation kind of further have helped develop these and make these safer and more efficient, and hopefully kind of shorten that learning curve a little bit. But there continues to be evolution, and as we sort of near the end of the talk, I'd like to highlight some of these personal experiences and interesting techniques that have kind of come across in the literature that may have some merits going forward. First of which is a single position lateral revision surgery for patients. So this was a case actually from my intern year of Dr. Yurkov's at the VA. A patient had metastatic hepatocellular carcinoma, had a T12 pathologic fracture, had undergone a previous corpectomy, and had probably at least 5+, if not even close to 10 surgeries for hardware failure, rod breakages, screw loosening, all kinds of things over the years. Eventually presented to Dr. Yurkov, the images on the left, the CT scan, there's bilateral broken rods, as you can see in that fluoro image on the bottom, as well as this interbody collapse and subsidence, and kyphosis there at that level at T12L1. And so images on the right demonstrate what we did, which is a single position revision corpectomy with simultaneous rod replacement. So I'll show you some kind of intraoperative images, which for me was really cool. I was an intern, wasn't that familiar with doing spine surgery. And so Dr. Yurkov had told me, oh, yep, you're going to expose the spine, expose the old hardware in the lateral position. I had, barely done any exposing of the spine in the prone position. So it's a great learning experience for me. And he allowed him to, simultaneously do the lateral exposure, pull out the old corpectomy cage, drill it out, kind of, was able to get it out of there. And so you can see on the left picture is the exposure of the rods, which we were able to subsequently remove, pretty easily, pull off the screw caps and had everything nicely exposed. Ultimately, those rods were replaced, but the other sort of nuance was that the image on the right shows placing a short temporary rod within the screws at the T12L1 interbody space. And I was able to distract on those simultaneously while Dr. Yurkov was placing the interbody graft to provide a little bit better fit and place the graft in a more appropriate position. And then that temporary rod was removed and we put the full rods in and finished the case. So the only interesting point in addition to the surgical technique was that this is a SPECT images of the patients getting cancer surveillance SPECT imaging every few months related to his cancer care. And we noticed that the image on the right is sort of immediately post-operatively within about a month or two. You can see both kidneys have some metabolic activity within them. But as you start going towards the left of the screen, the left kidney slowly loses that hypermetabolism. And by the time it's all the way on the left image, the kidney is a bit more atrophic and there's no activity left. And so this was sort of noticed on follow-up images over the course of several months, probably within about 4 to 6 months after the surgery. And we're still a bit unsure. There's no case reports in the literature of kidney atrophy on the ipsilateral side following fusion, following a lateral approach. That we didn't see the kidney. There was no ureteral injury in surgery. He never really had any like creatinine elevations or AKI, which has been reported in the literature after lateral surgery a few times. So it's sort of puzzling. I think an interesting complication that still sort of doesn't quite have an answer, but something worth noting to be aware of, down the road that is a potential possibility, particularly, I guess, if patients that only have one functional kidney on the left side, that, should be considered. This is from a more recent case from an OLIF we did towards the end of my VA rotation. Again, it was a revision, so he hadn't had any prior interbody cages at that level, so at L5S1. So Dr. Yurkov there is putting in a 5-1 graft while I was posteriorly exposing the old screws, again, to loosen the screws a little bit to allow for better distraction of the rods that were already existing in place to help facilitate the placement of the interbody graft. So a lot of things you can do from a single position approach, simultaneous surgery, being able to allow you to help facilitate, graft placement, better interbody, preparation from the simultaneous posterior exposure. Does make it a bit more challenging to kind of expose sort of, a little bit upside down. But again, with the learning curve, I've done a couple of these now and obviously, slowly become more and more comfortable with it. And then in the literature, interestingly, there's been now single position surgery, lateral surgery for treatment of thoracolumbar fractures, both traumatic and pathologic. So this was a series of 12 patients that underwent single level corpectomy and then posterior pedicle screws. 67% were traumatic fractures with a handful of 3 of the patients demonstrating acute spinal cord injury, 2 of which were incomplete. And they used this single position, lateral decubitus to do the entire procedure. It is, however, important to note they out of the 12 patients, 2 of them required reoperation due to persistent neural compression. One had a persistent radiculopathy, and the other had a retropulse bone fragment that wasn't completely removed, that required revision. So, albeit it may be a useful technique, it's still something that's maybe needs a bit further refinement and larger series to really determine if this is a feasible and safe option for these trauma patients, or particularly in positioning patients in the lateral if they have an unstable spine or cord compression. And so while single position surgery in a lateral decubitus position has been more well established, recent reports have described sort of a small series of prone lateral single position surgery that I kind of briefly mentioned earlier. So it's a picture from the initial series of Lamartina and Bergiano, their pro XLIF setup, as they called it. They described this approach in 7 patients. And what they found was that preparation time, like preoperative, kind of prep, draping, all that time, and X-ray exposure were greater compared to their standard lateral approaches, but that the placement of the actual lateral inner body portion from the prone position was similar, about the same length of time it took them to do it from a lateral decubitus position. Again, also important to note, they had 2 intraoperative complications in the prone group only, one of which was a partial cage subsidence, and the other, actually, the ALL was ruptured, requiring the insertion of a cage with screw fixation to prevent migration. And so building off of this, Dr. Uribe subsequently published a series of feasibility study with 2 cadavers looking at the prone lateral access, followed by then a 12-patient case series. Only 1 patient in their group required intraop conversion to the standard lateral decubitus positioning, which they attributed to excess abdominal girth. They essentially said that the instruments couldn't reach the disc space. They weren't quite long enough, because when the patient was in the prone position, the abdominal fat kind of bunched together and made that while normally in a lateral position but not have been an issue, it became more of an issue with the prone positioning. So they said that, standard approaches should still be used for more challenging cases such as like a high riding iliac crest, significant obesity, potentially sort of transitional anatomy. So while the prone lateral doesn't replace standard lateral procedures, it could be considered in select patients. And they kind of, review some of the advantages such as navigation. They argue that, in prone lateral, there's a slight advantage in navigation because you can anchor on either bilateral iliac, or PSIS joints as opposed to the iliac crest. That may provide a bit more stability for the, for the navigation arm. You can also potentially have the option to do direct decompression or facetectomies, from a prone position, which you cannot do in a lateral position, or at least makes it significantly more difficult. Screw placement they felt was a substantial advantage in prone lateral. It's just more natural, what we're more used to doing. But again, patient obesity and was made it more difficult. And then just a couple more interesting approaches. This sort of for like a high thoracic spinal tumor, recently published on using a higher thoracotomy coming in from a more lateral approach, as well as muscle sparing to the anterior cervical thoracic or upper thoracic vertebrae. Traditional techniques sort of transect these shoulder girdle muscles and can lead to a lot of postoperative shoulder dysfunction, but using these muscle sparing techniques for this high thoracotomy approach can treat these ventral cervical thoracic or upper thoracic spine lesions, which can be much more difficult to treat surgically and basically via the access. And then one last point is a recent neurosurgical focused video of an anterolateral transthoracic endoscopic approach for calcified disc herniation. So sort of combining not only lateral access, but also endoscopy, both of which are gaining a lot of popularity. And so here is just a couple images sort of doing curetting out the rib head overlying within the thoracic cavity. They've retracted the lung out of the way within the thoracic cavity on the left there, and they're kind of using an osteotome to take out the rib. And then the image on the right is the kind of section of the rib being removed with the dura sort of towards the top of the screen, and using a curette to remove that calcified disc fragment out of the disc space. So interesting technique, obviously not too common, but kind of shows the breadth and scope of what new techniques and different approaches can do in order to treat some traditionally very difficult pathologies. So in summary, lateral access to the spine has been adopted, refined over many decades now. Lateral interbody fusion has become an increasingly popular option for lumbar interbody fusion, as we all know. But further development, such as ACR, single position surgery, continues to push the boundaries of what lateral access can achieve. And of course, additional papers are going to be needed to really kind of, explore just how effective and safe these new techniques are. But that's all I have for you. Thank you for your time. I'm happy to take any additional questions.